Hi, everyone. On today's podcast, we're going to talk with our new research editor, Erin Wilson, about the updated evidence on big babies. Welcome to the Evidence-Based Birth Podcast. My name is Rebecca Decker, and I'm a nurse with my PhD and the founder of Evidence-Based Birth. Join me each week as we work together to get evidence-based information into the hands of families and professionals around the world. As a reminder, this information is not medical advice. See ebirth.com/disclaimer for more details. Hi, everyone, and welcome to today's episode of the Evidence-Based Birth Podcast. Just a quick content warning before we begin. We will be talking about the research statistics on shoulder dystocia as well as stillbirth. Now, I'm so excited to welcome Erin Wilson to the Evidence-Based Birth Podcast. Erin is a clinical researcher who is also a birth doula and childbirth educator. She has an undergraduate degree in biology, a minor in English, and a master's degree in public health. Erin currently lives with her family in a rural area in the mountains of Colorado, which has given her the opportunity to spend more time with her young daughter, Evelyn. As things have settled down and schools have begun to reopen, Erin recently started looking for remote work opportunities. Erin always loved the mission and values of evidence-based birth and has traveled to 2 of our live events before. So she jumped at the chance to bring her unique skills and experience to work with our team as a new research editor here at EBB. In addition to her new role at EBB, Erin is currently teaching remote perinatal education classes a few times a week. She also works part-time for a local nonprofit doing data analysis as part of a Colorado initiative to decrease the primary cesarean rate. Over the past few years, Erin's focus has shifted from one-on-one birth work to a more policy-level change. Her overarching goal is to make quality health education and healthcare more accessible. Erin says that while she has long appreciated and referenced the work that we do here at EBB, the pandemic has further illuminated the importance of clear, evidence-based, scientific communication for all. Any work that furthers this goal is something Erin says she's excited about. And she says it feels like an incredible bonus that this particular role is not only birth-related, but here at EBB. And we here at EBB are so thrilled that you are here, Erin. Welcome to the Evidence-Based Birth Podcast.
Thank you so much, Rebecca. I'm so excited to do this first podcast, and I'm so excited to be a part of the team at EBB.
So we gave you your first assignment when you came on board this summer was to update the research evidence on big babies. Can you tell our listeners, did you have any prior experience with this subject of big babies? Maybe any personal experience or doula experience?
I did. Yeah, I was really excited for this to be my first assignment. I had a lot of experience with this topic as a birth doula. I saw a lot of inductions for suspected big babies, and it did frustrate me that once this seed had been planted, it was so hard to shake it, and it created so much anxiety. So I think the mental component of birth is often overlooked, and I love that this article touches on that, and it shows that there is a link between a birthing person's mental state and labor progress in research. In my experience, there were a lot of times that these inductions or these cesareans would happen, and then the baby born would be in the 7-pound range. And then on the flip side, I have seen a handful of surprise babies in the 10-pound range. One really notable one was even a VBAC and came out weighing over 10 pounds with no issues. And it was hard for me not to focus on that seed had never been planted. And so we never thought that this might be a big baby.
So you've seen firsthand how people are treated differently depending on whether or not a big baby is suspected?
Absolutely. Yeah, I've seen a lot of people go down that rabbit hole of getting induced early or having the discussion of a planned cesarean. And then it's so hard for that person to not always go back to in their mind, is this because my baby's big? How big is this baby? And then as labor progresses, if that person is in labor, they question repeatedly whether things that are happening are because maybe their baby is big. So I've seen that a lot.
Okay, and I'm sure your experience is not unique because we still hear from a lot of doulas who follow evidence-based birth that they say that they have this similar problem. Like it continues to be a problem with their clients being told they have big babies. So I want to tell everybody a little bit what's covered in the article, and then I think what we'll do is I will ask Erin some questions about the research, and then we'll flip sides and Erin can ask me some questions about the research. So you can hear from both of us because it's usually a team effort to work on these articles. So in this article, we cover what is a big baby? How do you define a big baby? We also talk about routine care for when a big baby is suspected And the 5 assumptions that often drive care for families with suspected big babies. Those 5 assumptions that healthcare providers often make is that number 1, big babies have a higher risk of their shoulders getting stuck, also known as shoulder dystocia. Number 2, big babies are at higher risk for other birth complications. Number 3, we can accurately tell if a baby will be big at birth. Number 4, doing an induction keeps the baby from getting bigger, which lowers the risk of cesarean. And number 5, elective cesareans for big babies are beneficial and don't have any major risks that could outweigh the benefits. So those are the 5 assumptions that we often see in healthcare workers. And so what we do in this article is we kind of go through each one of those assumptions and look at the research evidence. And what does the research actually say? And how does it answer those assumptions? Are they true? Or are they not true, or are they somewhere in between? So Erin, let's start with you. When we look at the research, what is actually considered a, quote, big baby?
So there's a little bit of debate on that. There's 3 different categories that we talk about a lot. Some researchers will consider a baby to be big if it weighs over 8 pounds, 13 ounces, or 4,000 grams. Some consider the cutoff to be over 9 pounds, 15 ounces, or 4,500 grams. And then there's the extremely large babies, which everyone agrees are big. And those are babies that weigh over 11 pounds or 5,000 grams. And so we talk about that a lot in this article, and we reference them as grade 1, grade 2, and grade 3. And we see that the potential risks that we discuss sometimes can increase along a spectrum with size. So there are actually some protective effects of having a bigger than average baby, but where we do see some increases is in the biggest of the big babies. And so obviously this whole thing is about big babies, but I think it's good to just point out that only 9% of the babies that are born in the United States even meet that first cutoff of being over 8 pounds, 13 ounces. And only about 1% of them meet that second cutoff, over 9 pounds, 15.
Okay, so grade 1 would be considered being 8 pounds, 13 ounces to 9 pounds, 15 ounces, and grade 2 would be 9 pounds, 15 ounces or more.
That's right.
Okay.
Yeah.
In looking at the statistics, we found that it's only about 8.9% of babies are in that first category, and only 1.3% are 9 pounds, 15 ounces or higher. So we're talking about around 1 in 10 babies is born big. Is that correct?
That's correct.
Okay.
Yeah.
All right. So how do we know if somebody's going to have a big baby? Is it possible to accurately predict if a baby's going to be big? What does the research say about that?
That's the $1 million question, right? So in the US, we will typically give a lot of people ultrasound. So about 2/3 of pregnant people will have an ultrasound in the 3rd trimester just to estimate their baby's size. So that's the main way that we tell. We also do physical exams, so palpating a belly, measuring a belly. Most of the studies that we review show that an ultrasound's ability to predict whether a baby's big or over 8 pounds, 13 ounces is less than 50%. And predicting if a baby's over 9 pounds, 15 ounces is even less accurate. So depending on which study you're looking at, about 22 to 37% accurate. And we know that ultrasounds are a little bit more accurate in diabetics only because these babies are more likely to be larger if their birth parent's diabetic. Physical exams, which is the other main method, are similarly accurate about 50% of the time. And then we also look at research from some less common methods. Some other things that can be used are 3D ultrasounds. And then there's some different formulas that can be calculated based on different ultrasound measurements. And so these are shown to have about the same accuracy. And then one thing that's getting reviewed right now, and something that maybe we'll touch on in a future version of this article, is there's a possibility that MRI could be more accurate, but this is really expensive, and so it's just not as practical to screen everyone this way. But there is a study going on right now in Belgium. And so, like I said, maybe you'll see this in a few years if new data comes out before we do the next update.
Okay, so basically everyone kind of has a baseline chance of about 1 in 10% of having a big baby. But if you have an ultrasound and they say you have a big baby, then you have about a 50% chance of having a big baby, like a 1 in 2 coin flip almost.
Yes, exactly.
Okay. And some people say that, well, ultrasound techniques have improved, so our accuracy of predicting big babies has improved. Did you find any evidence for that to be the case?
I didn't. And I wondered that myself as I was going through this now that 3D ultrasounds are becoming more widely available, more common. But there's no evidence that these more high tech ultrasounds are more effective at determining whether or not a baby will be big than an older type of ultrasound.
Okay. So, and we were kind of skipping ahead through the assumptions. This was assumption number 3. We can accurately tell if a baby will be big. And the research shows, how would you say, what's the bottom line about that?
I would say we can tell half the time. So
No.
When we say that a baby might be big, when a care provider says that a baby might be big, they are right half the time and wrong half the time. So I would say no, we can't accurately tell if a baby's going to be big.
Okay. So what about the risks of having a big baby? Does it really matter if the baby is born big? I know it's difficult to predict how much a baby will weigh until it's actually born and we can weigh it. But what are the risks if you were to have a big baby?
So one thing that can be a little bit confusing is that if we suspect a baby's big, then that leads to these higher rates of induction and cesarean, like we've talked about. And so the data can be pretty complicated to gather and to interpret because deliveries that start with inductions and cesarean deliveries can lead to other types of complications like more severe tearing, postpartum hemorrhage, more NICU admissions for babies. And so it's difficult to separate whether these outcomes are from the big babies themselves or from the interventions that can happen when we suspect that there's a big baby. So that's one side of the answer. And then I do want to talk about a couple of things that you alluded to at the beginning that we do know increase with bigger babies. So shoulder dystocia that you mentioned at the beginning is when a baby's shoulders get stuck at delivery such that the care provider needs to take extra physical action to get the baby out. And so it's not a bad outcome on its own, but it is a bad outcome if there's any permanent nerve damage to the baby. And so one thing that Anna, who's the former research editor who I was lucky to take over for, she talks a lot in the article about how when care providers train annually to treat shoulder dystocia, they can lower and in some cases eliminate permanent nerve damage. And it's important because we've already talked about how we don't know if a baby's going to be big. Also, shoulder dystocia doesn't only happen in big babies. It can happen in smaller babies as well. So I'll give you some rates of how we do see that this increases along that spectrum of size. So in babies that weigh less than 8 pounds, 13 ounces, that first cutoff that we mentioned, less than 4,000 grams, 0.6% of those births will have a shoulder dystocia. And when a baby weighs over 8 pounds, 13 ounces or over 4,000 grams, 6% of those births can have a shoulder dystocia happen. And then when a baby meets that next cutoff of over 9 pounds, 15 ounces or over 4,500 grams, 14% of those babies can experience a shoulder dystocia. So even though the rate is higher in big babies, because there are so many more small and average size babies, about 50% of shoulder dystocias that occur are in smaller or average size babies. So like I said earlier, this can happen in a smaller baby, but it does happen at a higher rate in bigger babies.
Okay. And can you explain a little bit more about shoulder dystocia if you're able? Because people often, there's a lot of confusion about what shoulder dystocia is. So could you talk a little bit about the definitions of that?
Of what a shoulder dystocia is?
Yes.
Sure. So a shoulder dystocia is when the baby's head is born and then their shoulders get stuck at delivery so that the care provider has to take this other type of physical action to help them to come out. And so this happens in birth and baby comes out and it's fine. It only causes a different type of sequence of events if there is nerve damage to the baby's neck or shoulder because of the birth or the physical maneuver that the care provider performed.
So there are some physical maneuvers such as like pulling on the baby's head would cause nerve damage as the shoulders are stuck. Okay.
Yes. And what I wanted to say, and I don't know if you were going to ask me about this or if you want to go into it more, but there's this really nice table in the article because I think when we say shoulder dystocia, it can sound scary. And so there is this table in the article that really breaks down how many babies have a shoulder dystocia and then how many of those lead to nerve damage and how much of that nerve damage is actually permanent. And so what you see is that even in the biggest of the big babies group, about 0.5% of these babies actually have a shoulder dystocia end up with permanent nerve damage. And so it sounds like a small number. It is more than in babies who weigh less than 8 pounds, 13 ounces. In those babies, 0.009% of them experience permanent nerve damage. But as you can see, it's a very small percentage of the already small percentage of babies that experience this during delivery.
Another thing I hear healthcare workers saying to families is that you have a suspected big baby and therefore they are at higher risk for stillbirth. Can you talk a little bit about the risks and statistics on stillbirth and the size of the baby?
Yeah, absolutely. So in the previous version of the article, we reference a study from Scotland that analyzed 1,100 stillbirths. And researchers found that the smallest babies, so the ones born in the 1st to 10th percentile, had the highest risk of stillbirth, and that the biggest of the big babies had the second highest rate, so those in the 98th to the 100th percentile. The group that had the lowest rate is the big babies, the ones born in the 91st to the 97th percentile. So for the biggest babies, some of the stillbirths were related to uncontrolled diabetes in the birth parent, but some were unexplained, and so they are attributed to the size of the baby. In this new version of the article, we add a more current study, and this is in the updated article. It's a medical records review of about 110 million births that happened at full term in the United States over the last 4 decades. And so of this group, 10% were big babies, and this group had a rate of 1.2 stillbirths per 1,000 births. And in the remaining 90% of the babies, so the small to average weight range, the rate was 1.2 out of 1,000 births were stillbirths. And so when researchers further divided the big babies into the 3 grades that we talked about by size, they got really similar results to the Scottish study in that the smallest babies had the highest rate of stillbirth, followed by the biggest of the big babies. And once again, the big babies that were below the 98th percentile had the lowest rate. And so the researchers in this article, they emphasize that the risk of big babies increases along the spectrum that we've talked about. So not all big babies should be treated and managed in the same way.
Okay. So when you were saying small babies have the highest risk of stillbirth, we're basically talking about like growth restricted babies, intrauterine growth restriction.
Right. We're talking about really small babies.
Really small babies. But the big babies that are grade 1 are actually at the lowest risk of stillbirth of any of the sizes.
Correct.
Okay. And then it's when you get to grade 3 of the extra big babies, as we like to call them, that they're at higher risk.
Yes, that's right.
Okay. And I did want to point out all of this information is available at ebbirth.com/bigbaby. We also have a 1-page handout that you can feel free to download with some of this information, but we're not going to go into too much depth about all of the potential complications that may happen with big babies. But in the article we do, so you can look at the risks of unplanned cesareans, perineal tears, postpartum hemorrhage, and other newborn complications. And that's all in the article laid out for you with all of the research references. But when we we're talking about those assumptions, we had assumption number 1, big babies are at higher risk for getting their shoulders stuck or shoulder dystocia. What's the reality? What's the bottom line about that?
The bottom line is they are at a slightly higher chance of experiencing a shoulder dystocia.
Okay, but most of these cases can be handled by a care provider without harmful consequences. And some babies do experience permanent nerve injuries, but that can be reduced by having healthcare workers that do drills or practice the maneuvers so that they know how to handle a baby with shoulder dystocia.
Correct. And that's so important because, like we've talked about, shoulder dystocias can happen in any size baby. We can't accurately predict when they're going to happen, and we can't accurately predict when a baby will be big.
Yeah. So it's a kind of emergency that any healthcare worker, their teams should be training on how to handle for safety reasons, regardless of the size of the baby. And then the other assumption we had mentioned at the beginning of the podcast is that big babies lead to a higher risk of health problems and complications. And I think the reality of that, the facts show that the risk of complications with a big baby do increase along a spectrum, but also the care provider's suspicion of a big baby carries its own risks.
That's right. And that was one of the things that I found so interesting about this article. And one of the questions that I was going to ask you, which is, could bringing up a suspected big baby be more harmful than beneficial?
Yeah, so this is really interesting because it's been studied for quite a few years now, and we keep finding more and more studies on this topic. Does identifying a pregnancy as being pregnant with a quote big baby cause more harm than benefit or more benefit than harm? And time again, researchers have shown that suspecting a big baby can lead to a series of events that may be more harmful to babies and birthing people than the size of the baby itself. Not only does telling someone that they have a big baby increase the chance of having a cesarean or an induction, but there's also higher rates of having a stalled labor where labor does not progress normally. And there's higher rates of distress, fetal distress for babies during labor, and also distress for the families who are told that their baby is big, more anxiety, regardless of whether or not this is true. So just to share with you some examples of this research, there are actually 9 or more studies on this topic, all showing that it's the suspicion of a big baby, not the big baby itself, that leads to higher rates of labor induction, higher rates of cesarean, and higher diagnoses of stalled labor. For example, there was a study published in 2019 by Dude et al. They were looking at about 2,800 people giving birth for the first time who had these are people who are all plus size. They had a body mass index of 35 or higher. And this is often something that plus size birthing people often have to face, is kind of suspicions that their baby will be too big. And out of everyone in this study, 23% had an ultrasound to estimate the baby's weight within a month of birth. And the people who had an ultrasound to estimate the baby's weight were more likely to have an unplanned cesarean, usually for stalled labor, than those who did not have an ultrasound estimated fetal weight. Also, having an ultrasound to estimate the baby's weight was linked with a higher rate of cesarean, even after controlling for all the other factors that could have impacted the cesarean rate, including the baby's actual birth weight. So out of the 636 participants who had an ultrasound to estimate their baby's weight, 143 of them were told their babies were large for gestational age, meaning that they were over the 90th percentile. And this group had a cesarean rate of 61% compared to 31% among people who were not told that their baby was big. However, when the babies were actually born, only 44% of the people who were told they had a big baby gave birth to a baby that was large for gestational age. The same group of researchers also looked at people who were taking medication for high blood sugar. There was a study published in 2018, and they found similar results among people with gestational diabetes. Again, if they had an ultrasound to estimate their baby's weight, they were more likely to have an unplanned cesarean, even after considering the baby's actual weight. And the authors concluded that, quote, perceived knowledge of fetal weight may affect decisions providers make regarding how likely they feel their patients are to deliver vaginally, end quote. So what we see is that physicians are more likely to turn to a cesarean in a situation where they think there's a suspected big baby, and that there's a cultural fear of big babies in the healthcare provider field. In one medical journal editorial that we found from 2014, was written by Campbell, an obstetrician who seems to have a clear bias towards cesareans for big babies. And he basically said that we need vitally important that we flag all cases of suspected big babies so that everybody in the labor hall will recommend cesarean if there's any delay at all in dilation of the cervix or if there's any abnormal fetal heart tones. So it almost like creates a flag on your chart or on your record when you're told that you have a big baby that then makes everybody think, oh, we need to do a cesarean at like the slightest hint of anything going wrong. So although big babies are at higher risk for some problems, the fact that a care provider may perceive there is a big baby carries its own set of risks, a risk of unnecessary intervention. And it changes the way the care provider behaves and how they talk to people about their ability to birth their baby. So, and Erin, you've seen that firsthand as a doula. So just kind of asking you, what kinds of things have you heard care providers say to families when they think there's a big baby?
Oh gosh, I've heard all kinds of things. Your labor is taking such a long time because we know your baby's so big, or even a little bit of fear mongering and like, oh, your baby could get stuck at delivery. We could have to use an instrumental delivery because your baby's so big. I don't know. It's wild to me to have heard these kinds of things over the years. I read this article when I was just an EBB fangirl before I worked here. I read it many years ago in my doula practice, and then to revisit it now and see like, gosh, we only know half the time if a baby's even going to be big. And this gets spoken about just with this high level of confidence. That's just very interesting to me to see, oh, well, half the time we're right and half the time we're wrong.
But that's never brought up in the discussion.
No.
It's never brought up. No, it's not like, well, there's a 50% chance you have a big baby. It's you have a big baby and your labor's taking too long.
Yes. Yeah. I feel this doesn't really have to do with the studies that you just brought up, but I felt very fortunate in my experience to be under the care of midwives when I had my daughter, because my husband was born weighing 10 pounds, 11 ounces. And I know you and I talked about this a little while back, but I feel like you said before, it's such a cultural issue, such a stigma, I guess, in our culture that babies will be big. And, you're pregnant, you kind of lose your anonymity. People want to talk to you about your pregnancy. And I can't even tell you how many people came up to me and commented either on the size of my belly, the size of my adult husband standing next to me. Oh, your baby's going to be huge. Look at this guy, and it does get in your head, and it's really hard to shake that.
Yeah, it gets in your head. It makes you fear tearing during childbirth. It makes you fear pain. It makes you doubt your ability to do this. And it makes you more suggestible to, suggestions that you have a surgical birth because of the size of your baby, because you start to doubt your ability to give birth to this baby, even though we don't know for sure what the size of the baby is.
Yes, and we don't know, even if baby's big, if that would actually cause any issue. Most of the time it wouldn't. So it's so interesting. But You talked before about the different rates about cesarean when we suspect a baby's big. We didn't talk that much yet about induction. Is there evidence that induction can be beneficial for a suspected big baby?
Yeah. So one of the big assumptions in the medical field is that doing a labor induction allows the baby to be born at a smaller weight, which then helps you avoid shoulder dystocia and the risk of cesarean. But there's conflicting evidence on that. That's the reality. We don't know if induction for suspected big babies can improve health outcomes. And there's three main pieces of evidence on this. The most recent is a Cochrane review that was published in 2016. And in this study carried out by Bulvain et al., they combined 4 studies in which about 1,200 non-diabetic pregnant families with suspected big babies were randomly assigned, like flipping a coin, to either be induced between 37 and 40 weeks or to wait for spontaneous labor, which we call expectant management. And when they compared the induction group to the waiting group, they did find a decrease in the rate of shoulder dystocia in the induction group. There were about 41 cases per 1,000 births in the elective induction group, down from about 68 cases per 1,000 in the waiting group. And they also found a decrease in birth fractures, such as collarbone fractures, in the elective induction group. There were 4 per 1,000 in the induction group versus 20 per 1,000 in the waiting group. And they said to prevent one fracture, such as a collarbone fracture, it would be necessary to induce labor in 60 people. On the other hand, they found an increase in severe tears in the induction group, which would be surprising to some people. There were 26 severe perineal tears per 1,000 births in the induction group versus 7 per 1,000 in the waiting for labor group. And there was also an increase in the need to treat jaundice in babies in the induction group, 11% versus 7%. On average, they found that babies weighed about 6 ounces less when labor was electively induced early compared with those who were assigned to wait for labor to start on its own. And there were no differences between groups in rates of cesarean, forceps or vacuum, NICU admissions, nerve injury due to shoulder dystocia, or low APGAR scores. And there were 0 deaths in any of the studies. Researchers did not look at satisfaction with care or any long-term health results for families. So with this information on induction, It also helps to go look at like the largest study in the Cochrane Review, in which they followed 818 people with suspected babies who were randomly assigned. And it's important to understand that most of them were actually assigned to be induced to labor between 37 and 38 weeks, which is not typically done in the United States or other countries. It's being discouraged to be electively induced before 39 weeks. So you got to kind of take all of this research with a grain of salt. They were actually looking at people who were being mostly induced pretty early, before 39 weeks, when that is not even considered an option these days to have an elective induction before 39 weeks. So that makes the evidence a little bit harder to interpret, because all of this evidence about, yes, it does decrease shoulder dystocia. Yes, it decreases the weight by 6 ounces. But that's if you do a really early induction between 37 and 38 weeks, which is not something that we're doing. So it doesn't seem. The other thing that's interesting is that although they found a decrease in the rate of shoulder dystocia, it didn't seem to have any impact on any actual health outcomes of NICU admissions. So babies were less likely to be admitted to the neonatal intensive care unit. There was no effect on that by being induced early.
Interesting. So I wanted to say, just to add to what you were saying about the early inductions, Rebecca, one of the things that we added to this new version of the article were some new guidelines. And so one thing is a practice bulletin that ACOG put out, the American College of Obstetricians and Gynecologists. And it's just further clarifying that I guess I should say it's specifically talking about inductions for a suspected big baby to prevent shoulder dystocia. And so ACOG clarifies that this idea, inducing somebody early before 39 weeks because of a suspected big baby to prevent shoulder dystocia, is not a significant reason. So this isn't something that would fall into the category of inducing prior to 39 weeks.
It's not a medical indication having a baby. Okay.
Yes. Yeah.
Was there anything else we should know about updated guidelines that we added to the new article?
Well, so we added a big section about this ACOG practice bulletin that I just mentioned. And then we also added something that came out from NICE, the National Institute for Healthcare Excellence, which is in the UK. This was about induction, but it really wasn't specific to big babies. But in May 2021, really recently, NICE released this draft bulletin, and it suggests that all pregnant people should be offered induction at 41 weeks versus waiting for labor to begin at 42 weeks. And this is, again, not specific to suspected big babies, but with the idea that everyone should be offered this to prevent babies from getting too big. And this really isn't based on a specific research study. There's no statistics or evidence involved in this practice bulletin, but it's based on expert opinion. And I don't know how you feel, Rebecca. It was interesting to me to read this because my experience in the United States is most people do not wait when they're giving birth in a hospital system for 42 weeks. Like 41 weeks feels like a more realistic time that I see people be offered induction versus 42 weeks. But again, this is coming from the UK, where it seems like people get to wait longer to have their babies.
Yeah, and that also may affect some of the randomized trials, when they were randomly assigned people to early induction versus waiting for labor to start. Often they would wait until 42 weeks, which today you don't see that as often in the United States. So, but I think it's, just a good idea for birth professionals in particular who are listening to check out the article so you can have those links to the practice bulletins if you need them. And also, if you're interested in learning more about due dates and being induced at 39, 40, 41, or 42 weeks, you can go to evidencebased.com/inducing due dates to get to our article about that. And then also, we are going to be updating the gestational diabetes articles later this year. So if you're more interested about inducing for gestational diabetes, we do have information about that right now, but we're going to be updating that information later this year. So Erin, in kind of looking at all of this new information, what's the bottom line about the research evidence on suspected big babies?
So the bottom line is, for those that are not diabetic, if a care provider predicts that a big baby is coming based on an ultrasound or physical exam, They're going to be right half the time, and they're going to be wrong about half the time. About 7 to 15% of big babies have that difficulty with the birth of their shoulders that we talked about called shoulder dystocia. But the chance of a permanent injury due to shoulder dystocia is very, very low. And then if a care provider thinks that you're going to have a big baby, like Rebecca talked about, this thought is sometimes more harmful than the actual big baby itself. And so although a policy of really early induction can prevent some shoulder dystocia cases from happening, researchers are really not able to show that that decreases the risk of permanent nerve injury. And they're also not able to show that that outweighs the risk of early delivery to the person giving birth or to their baby. And so like we talked about, that was reaffirmed in this ACOG practice bulletin that came out earlier this year. And then for pregnant people that do have diabetes or gestational diabetes, ultrasounds are just slightly more accurate at predicting a big baby. And just like for people birthing that don't have diabetes, it's important for care providers to follow the standard definitions of slow labor. Elective cesareans might be a little bit more cost effective in pregnant people who have diabetes, but there's no strong data on how health outcomes for planning a cesarean. And so this is based on expert opinion only. And the other thing that's important for this bottom line is that management of gestational diabetes, diet, exercise, or medication lowers the chances of having a big baby and a shoulder dystocia down to the same levels as in people that don't have diabetes.
Yeah, and if you want to learn more about the information we currently have published on gestational diabetes, you can go to evbirth.com/diagnosing-GDM or evbirth.com/inducing-GDM. So thank you so much, Erin, for helping us work on this article and for coming on the podcast to explain the updates to our listeners.
Thank you so much for having me. It was really fun.
And again, you can go to ebbirth.com/bigbaby to get a free one-page handout on this topic, as well as to read the full-length text and click on any of the references that you want to take you straight to the research articles yourself. If you found this podcast helpful, we'd love it if you could leave an honest review on whichever podcast app you use to listen. And we look forward to seeing you next week. Thanks, everyone. Bye.
Bye.
This podcast episode was brought to you by the book Babies Are Not Pizzas. They're Born, Not Delivered. Babies Are Not Pizzas is a memoir that tells the story of how I navigated a broken healthcare system and uncovered how I could still receive evidence-based care. In this book, you'll learn about the history of childbirth and midwifery, the evidence on a variety of birth topics, and how we can prevent preventable trauma in childbirth. Babies Are Not Pizzas is available on Amazon as a Kindle, paperback, hardcover, and Audible book. Get your copy today and make sure to email me after you read it to let me know your thoughts.